Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule for Manual Therapy Part 2. We've got all the gang here together, so we got Lucas, Mark, and Drew. Thank you guys for joining us. Last episode, we tried to lay out what is manual therapy. And between Mark and Lucas, I got pretty much the gist being we're focused more on the clinical reasoning behind the manual technique that we're going to use, as opposed to just strictly the manual intervention or the manual technique that exists there. And so that makes a lot of sense to me. Today, what our goal is to talk a little bit more about why we should use it. So why is it beneficial? And so all three of the guys are going to tackle that. We also just started last episode an icebreaker question. So what I've got for you today, Mark, is if you are a superhero, what superpower would you like to have?
That's an easy one. I would go with teleportation. My first order of business would be to acquire money in some way, potentially bank robbery or some other way. And then I'm going to teleport all over and live wherever I want to and be there immediately.
Some people hope for world peace, and you took a different route, and I appreciate that. So appreciate the transparency. All right. So without further ado, let's go ahead and get into it, guys. So why is manual therapy important? I'm going to kick it over to you, Lucas. Start us off.
Manual therapy is a form where you give your patient that connection that he or she desires at the same time that you can adjust and assess things. For instance, we talked about plantar heel pain and insoles. I use manual therapy to assess which kind of insole, firmer or softer, by assessing with my hands the mobility of the foot. It also helps with guiding. While many physical therapists cue patients on certain movements they cannot perform, I use manual therapy as a form of resistance along with cueing, which is also a form of manual therapy. Bottom line is manual therapy gives that edge, that connection with the patient, the therapist and patient, that you can't have anywhere else other than using your hands. So it's a window of opportunity for the patient to take the pain down, connect with the patient so the patient can get moving again.
All right. So big keys from you, Lucas. One, the connection piece. Two, the extension of the assessment more so than anything else, and kind of gauging those two things together. So, all
I
right,
think the
Mark.
most important is
Oh,
that window of opportunity, that connection and window of opportunity to allow the patient to move.
Yeah.
yeah, creating a
The
window
only
of
thing
opportunity.
I'll add to that is that manual therapy can be tremendously effective in a small amount of time. There's a lot of research. If you look at the lumbar spine manipulation clinical prediction rule, and if the patient fits that criteria, you do a lumbar manipulation on them, they're 50% better in almost immediately. And that's something that there's very few interventions that we have in our toolbox that can have such a large impact in such a small amount of time. So, to Lucas's point, it is a window of opportunity. It is connection. There's a lot of physiological responses that occur as soon as you put your hands on a patient in a positive way, but it gives us the opportunity to do the exercises, the movements, the other things that we included with manual therapy to be most effective.
So, as clinicians, we want high value out of our time, and your belief, Mark, is that manual therapy is a great way to get some high value out of your time as well. So,
I like the word value. Yes, I like that a lot.
Also like that with the question itself kind of mentioned it, but why it's important and maybe not necessary. Like I think there's probably a lot of very, very, very good therapists who, with excellent clinical decision making, patient connection, are very, very good therapists. So is it necessary? Probably not, but is it helpful? Absolutely. And I think it's largely because of that window of opportunity piece, so that you can be more effective with the next intervention and the next intervention.
Yeah, I mean, that brings up a really good thought behind it. I mean, for you guys, like, I'll ask the easy, straight up answer. Like, is everybody getting manual therapy?
Not everybody, and almost nobody every single time. I think there's a progression that I'll typically use. Uh, Early on, I'm going to be a little bit more heavy on some of the manual therapy, one for the connection, but also creating that window of opportunity. But as they're moving from, like I tend to look at it with the treatment-based classification from like symptom modification to movement control and functional optimization. I look at those buckets. So if I'm in symptom control, often I'm going to use it quite a bit more. Even in some movement control, I'll use it a fair amount because it can improve muscle function, it can improve motor control, and things like that. So looking at it in a different way of not just decreasing pain or like trying to free up movement, but how can you improve muscle facilitation? I'll use it in that mindset semi-frequently. But then as I'm moving to that functional optimization piece, it's typically more of decision making on loading and progressions and getting them back to doing everything that they want to do.
Cool. Yeah, I think so the more acute the patient is, maybe we're considering this a little bit more so is kind of the drift that I'm getting consistently. We know the window of opportunity is created by it. We know most of the manual interventions that we're going to do are not going to be everlasting, right? I mean, that, the evidence doesn't show that. But if there's a time period, we know that people that feel better are going to move more, and that's what we're all looking for, to get more movement out of it. So, um, that said, so we've got the high value here. We've got a window of opportunity. We've got an ability to connect with a patient through this intervention, and we've also got the use of it early on with acuity in terms of getting some symptoms calmed down, getting people trusting movement a little bit more potentially. So what are our barriers? I think we probably recognize that not everybody is using it potentially as much as we could be, or as much as maybe the evidence says it's valuable too. So what are some barriers with manual therapy in the clinic for everybody that's in the clinic treating patients?
The most common one that I'll see is, or that I've recognized in myself and others as I've been practicing, is what I call provider fear avoidance, where the provider, for whatever reason, doesn't feel confident or proficient in a manual therapy or manual technique. And so, if I know that doing a cervical manipulation can help downregulate the nervous system and improve pain pressure thresholds in the lateral elbow. I know that. But if I don't feel comfortable performing a cervical manipulation, I'm not going to do it. And so that's the most common thing. So getting a lot of reps and being proficient in manual techniques and manual therapy is important. And then kind of going along with that, sometimes, and this is true even today, sometimes I find it a hard sell when someone's coming in for their lateral elbow and I'm saying, oh, I'm going to manipulate your cervical spine. So there's an education component that we need to be comfortable providing to the patient to help them recognize, like, this is a high value treatment option still, even though it's not directly to the body region that you are coming to see me for.
I will
Yeah,
I will shy
I would
away from using manual therapy. Oh, go ahead, Drew.
All right. Well, I want to add that because I think there's another benefit that we maybe missed here, and it's patient expectation. And kind of one of my soapboxes sometimes is when people are hurting, especially if it's neck and back, a lot of times what they think is going to get them better is they're going to crack my neck or crack my back. Like, there's a lot of people who really believe that, which is why chiropractors often do so well with spinal pain. And unless we are good enough and confident enough to do that, we will never be the one that someone thinks about was, oh, my back hurts. And if they think, hey, this is what I need, they're going to go look elsewhere for it. So I think I fully agree with Mark that the fear avoidance is a big piece of it. And it's also kind of a soapbox of mine is we need to make sure that we're good at it if we really want to own spinal pain.
Yeah, I think that's a good word. I think about dry needling as a means as well in that too. So many people when I started up here in Wake Forest came to this clinic because I was at the time the only person that did dry needling, and you had all these people coming in. I need to be dry needled, and nothing bothers me more than somebody walking in just telling me what they need from a treatment standpoint. But the reality is, at times, it was beneficial to be able to use that as, okay, you're in my clinic, great. So now I know that you want dry needling. Let's assess what's going on. And the reality is, the patient may not care about any of that. All right, we're going to dry needle you, but what I want to do is make sure that I'm going to give you what I know is going to be the beneficial treatment for longer lasting as well too. So patient expectation, I think, is a valuable thing to look at. Obviously, it can be harmful, and we want to make sure that we recognize and are able to separate out those two things in terms of patient expectation. But there's a lot of value to being able to do a little bit of what they think is going to get them better. Chances are, if they believe it's going to get them better, it has a good chance of being a piece of that as well. So I definitely I like that.
That's where I was going to circle back around where you saying what Drew said. In some occasions, the patient truly wants is the manual therapy. That's all they want is the manual therapy, right? I usually make an agreement with the patient in these cases for them to understand that the end result is the movement is getting better, less pain, doing more, right? We can start that way, but the therapy won't be focused solely on manual therapy.
And I like that as we're sliding back into the barriers that we're looking at. So we've got a coined phrase here: provider fear avoidance (PFA) from Mark himself. Anything else that we're seeing as the barriers in a day-to-day clinic? Maybe it's busy in there. What else do you think is preventing our providers from doing manual therapy?
I mean, I would say in a busy clinic, it's definitely a reality. A patient walks in and they are in a unexpected, unanticipated flare up, and all of a sudden I've got them scheduled in a place where I may have other folks running around in the clinic doing other things, or maybe even another patient that needs some manual attention. And now I'm in a bind where I'm like, crap, this patient needs my attention and needs this manual therapy to help them get them out of this flare up. And so something has to give in that situation. And so, I can't perform manual therapy on more than one individual at once. And so sometimes someone is doing a symptom alleviating activity while I'm doing manual therapy with somebody else, or vice versa.
Yeah, I think that makes sense. Obviously, everybody's dealing with those situations in the clinic at times, and so being able to figure out and plan ahead on that too. You're gonna have a patient or two that's gonna come in on your schedule, probably flared up that you weren't expecting, but being able to potentially use those to a goal. And I think the reality too is, you kind of mentioned the high acuity patient. We have evidence for a lot of manual therapy, manipulation, different things for being the best first line defense with these acute patients as well too. It's quicker. It's kind of get in and out, kind of restore some quick motion in that same line as well too. So we know that there's a lot of benefit to having that in the mix here as well, which I think is valuable. Go ahead, Lucas.
Oh, I think also we need to remember that one of a physical therapist's main a word that the physical therapist despises massage, right? What we call soft tissue mobilization. A lot of times has a
Yeah.
great value in managing that acuteness, like that irritability of the patient, and I don't shy away from that. Just to make sure that again we have a very clear agreement in terms of manual therapy is a path through which we want to achieve A, B, and C.
Absolutely. Well, cool. Went a little bit over today, but I think it was good as we dug into that. And I think our next episode, we will dig a little bit more into exactly where you were going to some degree, Lucas, and what we talked a little bit about earlier as well, too, in terms of preventing reliance on passive interventions. In some way, manual therapy exists in that bucket as well, too. So we'll look forward to talking on that next time. Appreciate you guys.
Thank you.